Nausea is the unpleasant physiologically protective sensation of impending emesis. There may be some retrograde peristalsis of the proximal small bowel. Retching are like dry heaves with closed glottis and contraction of the stomach antrum with relaxation of the cardian fundus. Regurgitation is a passive expulsion of ingested materials out of the mouth, pretty common in esophageal disease, where vomiting is a forceful expulsion of stomach contents. It involves deep inspiration, closure of the glottis and the raising of the larynx and soft palate, with contraction of the diaphragm and abdominal wall muscles. We'll see activation of the parasympathetic, leading to salivation, and activation of the sympathetic system, leading to tachycardia and sweating. The central pattern generator, CPG, also known as vomiting center, VC, is located in the medulla oblongata near the solitary tract nucleus, STN, also known as the chemoreceptor trigger zone, CTZ. It's in the area postrema, primarily activated by acetylcholine on muscarinic receptors. There are at least 4 sites that can relay info to activate the VC: the higher brain, things like sights, smells, and fears; the GI tract, particularly stomach and or chromaffin cells activating 5-HT3 receptors to send a signal through the afferent vagus; the vestibular apparatus, which relays info to the CTZ through cranial nerve 8, and the CTC on the dorsal surface of the medulla. It's a circumventricular organ on the floor of the fourth ventricle. It's a sensor, if you will, for toxins in the CSF and blood. It's penetrated with leaky, convoluted capillaries so that it can sense what's in the blood. This busy graphic is kind of a pharmacologist view of emesis. Let's start first with the inner ear and vestibular apparatus. Here we're going to treat with antimuscarinics and antihistamines with significant antimuscarinic activity. We get symptoms here caused by motion, by aminoglycosides, and by opiates. Sensory input, pain, smell, sight, memory, fear, dread, and anticipation can activate higher centers to feed directly into the emetic center in the medulla. We're going to treat this type of nausea and vomiting with the atypical antipsychotic with significant antimuscarinic and antihistamine effects, olanzapine. We may also treat it with benzodiazepines, like lorazepam. The area postrema chemoreceptor trigger zone can be activated by serotonin, dopamine, and acetylcholine. So we're going to treat with antagonists at those receptors: 5-HT3 receptor antagonist, dopamine D2 receptor antagonist, and muscarinic antagonists. Cannabinoid receptor agonists may also be of benefit here, as may glucocorticosteroids, which are not shown in the diagram. The solitary tract nucleus can be activated by serotonin at 5-HT3 receptors, dopamine at D2 receptors, acetylcholine at various muscarinic receptors, histamine at H1 receptors, and neurokinin 1 and NK1 receptors. So we may use antagonists at those receptors, and also sometimes cannabinoids at CB1 receptors to treat nausea and vomiting. Finally, directly at the level of the GI tract, we'll probably treat with serotonin 5-HT3 receptor antagonists and sometimes glucocorticosteroids. This chart summarizes what we're going to be talking about. I made it to help you sort out the actions of the drugs. For our purposes now, though, the most important point regarding what to pick for the type of nausea and vomiting is seen in red. To treat motion sickness, we really want to block muscarinic receptors in the vestibular apparatus. Antihistaminic action may also be an added benefit, so we often use antimuscarinic antihistamines like dimenhydrinate, Dramamine, which is a metabolite of diphenhydramine. Also think about the mechanisms in the context of adverse effects and concomitant conditions. For example, we see that metoclopramide is a dopamine D2 blocker. What adverse effect can you predict from D2 block in the extrapyramidal tract? Well, D2 block in the extrapyramidal tract may cause dystonia, Parkinson-like tremor, and akathisia acutely. And with chronic use, we might see tardive dyskinesia, similar to the typical antipsychotics like haloperidol. Let's do an application question. We have a 65-year-old with Parkinson's disease who presents to the emergency department with nausea and vomiting for the past week. It's associated with poor oral intake and significant weight loss. Her only med right now is the dopamine agonist ropinirole. Her vitals include temp 100, pulse 95, respiratory rate 20, blood pressure 90/60. Labs include low sodium, low potassium, low bicarb. Shortly after a rapid IV bolus of antiemetic is given, she suffers a syncopal event caused by an arrhythmia that was successfully treated with magnesium. Which appropriately ordered medicine was the culprit? Aprepitant, dronabinol, lorazepam, metoclopramide, ondansetron, or prochlorperazine. This is a toughie, way harder than would put on an exam. So the patient likely suffered from torsade, which is a ventricular arrhythmia that's treated with magnesium. A lot of drugs, as you are probably aware, can block that rectifying potassium channel, also known as the HERG, the human etheragogo channel, including items D, E, and F from this list. Since she has Parkinson's disease, we would want to avoid dopamine receptor blockers, hence the stem reads appropriately ordered. So the 2 important points from this question: number 1, many serotoninergic or 5-HT3 blocking drugs can block the HERG to prolong QTC. The risk is higher in patients with low potassium or low magnesium, as you've already learned. More importantly, blocking dopamine receptors in patients with Parkinson's disease shouldn't be a first-line approach to stop emesis because blocking dopamine receptors is going to temporarily make Parkinson's symptoms worse. The first class of drugs we want to talk about is 5-HT3 antagonists, the cetrons like ondansetron, generic name for Zofran. There's lots of uses here listed for you, but they're pretty commonly used antiemetic drugs. Adverse effects, as we've already seen, QT prolongation, constipation, headache, potential for serotonin syndrome, which may seem counterintuitive since they're antagonists, but 5-HT3 receptors decrease serotonin release by some neurons, and there's also, of course, a risk of hypersensitivity reaction. The best thing to know about these, in my opinion, is that they aren't going to interfere with the treatment of Parkinson's disease. You've already learned about the first-generation antipsychotics, so we have low-potency agents like prochlorperazine, compazine, promethazine, Phenergan that are very commonly used as antiemetic drugs. So their other actions, if you recall, are antimuscarinic, so anti-SLUD, delirium, antihistamine, which means they're sedating, sodium channel block means there's a risk of arrhythmia and a local anesthetic effect, and alpha-1 receptor block meaning that there might be some orthostatic hypotension and dizziness. We also have our high-potency dopamine blockers, haloperidol, Haldol, and droperidol, and Apsine. These two are seldom used as antiemetics due to the risk of acute dystonia and other EPS, QT prolongation, sedation, risk of neuroleptic malignant syndrome, hyperprolactinemia, and tardive dyskinesia with chronic use. The atypical antipsychotic olanzapine, generic name for Zyprexa, is sometimes used as an antiemetic. It's what's known as a dirty drug, though, because it interacts with a lot of different receptors. It's a strong antagonist at serotonin 5-HT2A and 2C. What do you predict based upon this? Well, you might predict that it will improve negative and positive symptoms of schizophrenia, and with chronic use there is a risk of weight gain. It blocks dopamine D1 through D4 receptors, so what do you think about block of D2 receptors? We may see dystonia, extrapyramidal side effects, hyperprolactinemia, and chronic use may pose a risk of tardive dyskinesia. It's an inverse agonist at H1 receptors. What do you think about that? Well, if you predict sedation and chronic use weight gain, you're correct. How about antagonism at alpha-1 receptors? Risk of orthostatic hypotension and dizziness. It's a moderate antagonist at 5-HT3 receptors, so here's probably part of its benefit as an antiemetic, as well as its block of muscarinic receptors. Don't forget, if we block muscarinic receptors, we might see anti-SLUD, including constipation and mydriasis. It's also a mild agonist at GABA-A receptors, meaning it has somewhat of a sedative effect. Importantly, as we already mentioned, antimuscarinic effects are really necessary for motion sickness efficacy. So our antimuscarinic antihistamines include dimenhydrinate, Dramamine, and meclizine, which is sold as antivertin Dramamine 2. They're H1 receptor inverse agonists, meaning that they can cause sedation or, in some people like me, a paradoxical CNS stimulation, long-term use associated with weight gain, and there's also some anti-nauseant effect, as we saw from histamine receptor antagonism. Antimuscarinic effects, anti-SLUD, and since this is a GI tract, think about constipation. We also may see delirium, tachycardia, diminished sweating, mydriasis, which remember can be bad in patients with angle closure glaucoma. A purely antimuscarinic drug is scopolamine, generic name for transderm scope. There's also an intravenous form that's used postoperatively to treat the symptoms caused by reversal of curare derivative neuromuscular blockers. Let's look at the adverse effects. So what do you predict? CNS from antimuscarinic, there may be some delirium. HEENT ophthalmically, mydriasis, cycloplegia, orally, dry mouth. Cardiovascular, tachycardia. Respiratory, we may see some bronchodilation. Gastrointestinal, decreased spasm, decreased peristalsis, maybe some constipation. Genitourinary, probably urinary hesitancy. How about integument? Well, remember, patients can't sweat when their muscarinic receptors are blocked. Metoclopramide, Reglan, is a benzamide. It's a dopamine D2 antagonist, and at higher doses it can block serotonin 5-HT3 receptors while activating serotonin 5-HT4 receptors. Adverse effects, well, extrapyramidal effects including acute dystonia, tardive dyskinesia with chronic use, drowsiness, hyperprolactinemia. There is a risk of neuroleptic malignant syndrome in susceptible individuals. It has lots of different uses, but do you really want to use this medication in a Parkinson's disease patient? It shouldn't be a first-line choice because of its ability to block those dopamine D2 receptors. FYI, NK1 antagonists are very expensive, so they're used primarily for severely emetic chemotherapeutic regimens to treat chemotherapy-induced nausea and vomiting. Dronabinol is a synthetic tetrahydrocannabinol, or THC, sold under the brand names Marinol and Syndros, so it's a cannabinoid. It's used primarily for its appetite stimulant effects. Its efficacy as an antiemetic is arguable. It has many effects, including direct partial agonism at CB1 receptors. It can turn on the metabolic regulator GPR55. It can activate TRPV1 ion channels, many other effects. Side effects include sympathomimetic effects. Of course, it can cause red eye. There is a risk of dependence and withdrawal. And I think both products actually contain some ethanol. Ginger, or Zingiber officinalis, has long been used for nausea. In fact, the authors of Up to Date suggest that women with nausea associated with morning sickness try consuming ginger-containing foods. Since gastroparesis is commonly associated with nausea and vomiting, I thought it might be appropriate to give an overview here. Gastroparesis is the delayed gastric emptying of solids in the absence of mechanical obstruction. In addition to nausea and vomiting, it's associated with early satiety, belching, upper abdominal pain, and regurgitation. Maybe it won't be surprising to you that some meds can cause gastroparesis, including opioids, alpha-2 agonists, dopamine agonists, antimuscarinics, or GLP-1 and GIP agonists, or dipeptidyl peptidase 4 inhibitors like sitagliptin, calcium channel blockers, octreotide, glucagon, and proton pump inhibitors. We'll end this session by looking briefly at the treatment of gastroparesis, mechanistically speaking. So, for nausea and vomiting associated with gastroparesis, of course, sometimes you're going to add just antiemetics in general, but let's look more pharmacologically. We might add the dopamine D2 receptor antagonist metoclopramide. We might add a modulin agonist, like erythromycin, FYI. We could also use a 5-HT4 agonist, not shown here, but FYI cisapride. And finally, due to side effects not commonly used, our cholinergic agents like bethanechol and neostigmine can help improve gastroparesis.